Hi everyone, thank you so much. Today I'll be talking about the medical management of gastroesophageal reflux disease going beyond PPI therapy. I have no financial disclosures, and also I've noted I won't be showing any cool videos like the previous two speakers just showed. And I will be talking about non-FDA approved therapy. So just to remind you how we actually make acid within our stomach, and it all begins in the gastric parietal cell. At the top, you have various neurotransmitters, and then I've highlighted the histamine 2 receptor on the basolateral membrane. This is where the so-called H2 blockers work, medications like cimetidine, which we don't see that much, ranitidine, which we shouldn't be seeing at all, and famotidine, which we see a lot. So that's where the H2 blockers work. Moving within the gastroparietal cell, there's coming together of calcium in the presence of G proteins and cyclic AMP, and then everything leads to the final common pathway, which is the hydrogen-potassium ATPase pump at the lumen of the gastric parietal cell. This is the so-called proton pump, and then ultimately you get secretion of hydrogen acid into the lumen of the stomach. And it's at this proton pump that obviously the proton pump inhibitors work. I gave a talk 2 years ago on the good, the bad, and the ugly of PPI therapy, as Dr. Gasemi recently mentioned. And thankfully, these kind of negative studies related to potential side effects or adverse effects from PPI therapy, we're seeing them less and less. But these were some of the original studies highlighting some potential issues with chronic PPI therapy. I think at this point in 2024, any issues with PPI safety is actually fake news. However, patients are concerned to take PPIs chronically, and oftentimes primary medical doctors aren't actually comfortable with prescribing chronic PPI therapy. And this is maybe, as you can see, why. These are the potential adverse effects that a patient with chronic PPI therapy might be exposed to. I think it's always important to make sure your patient who is on chronic PPI is taking it for the right indication, for the right reason, and at the lowest possible dose. And there's also a role for possible, de-escalation of therapy. Thankfully, about 5 years ago, this study came out, which really gave us, reassurance and data that chronic proton pump inhibitor use are safe. And in the study, what they specifically looked at were odds ratios of the various potential adverse effects. And if you look at the little graph at the bottom there, you can see there's this zone of potential bias where if an odds ratio falls between 0.33 and 3, you really don't know if it's that significant. And you can see in this study, all the odds ratios actually fall within this zone of potential bias. The two highest odds ratios are Clostridium difficile infection with an odds ratio of 2.26, but just to note, there were only 13 patients with 4 in the placebo group. The other slightly increased odds ratio of 1.33 was enteric bacterial infection. So of all the potential adverse outcomes or adverse effects with PPI therapy, the only slight signal perhaps should be with increased risk of enteric infections. And then obviously the evidence that was published, there's huge problems with that evidence. A lot of the studies were retrospective observational studies. There's major issues with relying on databases that look at RCD coding. Throughout these studies, we found a lot of confounding issues in terms of the dosage, the duration, and whether there was good compliance, in fact, with PPI therapy. We weren't sure if the correct indication for PPIs was being made, and oftentimes these patients were on PPIs for inappropriate reasons. I spoke about the differences between causation and association doesn't prove causation. I mentioned issues with odds ratios. The studies didn't really address that well, relative risk versus absolute risk. And we know that in these studies, the majority of the patients were often sicker and older and would tend to often get these adverse outcomes anyway. Just on a segue, there are 2 formulations in the United States, the so-called immediate release PPIs, immediate release omeprazole. The first on the left is a 20 milligram over-the-counter capsule of omeprazole, 20 milligrams of omeprazole with sodium bicarbonate. The other formulation is an omeprazole plus sodium bicarbonate oral suspension, and it's the only FDA-approved omeprazole liquid suspension. Where these immediate release PPIs might be beneficial is that they're not affected by acid, they're not enteric-coated, so potentially they can be given regardless of patient eating a meal. And I think they have the most benefit for treating patients with the predominance of nocturnal acid reflux symptoms. The options thus far are either taking a PPI twice a day, so you give a dose before breakfast and a dose before dinner, or you can add an H2 blocker at bedtime. But I think this is a novel way of perhaps treating nocturnal acid reflux symptoms. And this study clearly indicated that the patients who received this immediate release omeprazole versus standard pantoprazole, you can see that they had far higher gastric pH time and throughout the 24-hour period. So I think the role of immediate release PPI therapy is perhaps in those patients with a predominance of nocturnal symptoms. So patients don't like taking PPI therapy, so then we'll often recommend lifestyle modification as well as dietary modification. And unfortunately, once again, patients aren't always compliant with this. We usually recommend avoiding specific foods and beverages, acidic foods, carbonated beverages, coffee, alcohol, chocolate, mint, and spicy foods. The proposed mechanism for acid reflux in patients eating these foods are predominantly a reduction in lower esophageal sphincter tone, but for foods like acidic foods and spicy foods, there might be a direct esophageal mucosal irritation. In terms of the type of the food, foods high in fat and carbohydrate might also reduce lower esophageal sphincter tone. And then, how we eat and when we eat. So avoiding large meals and specifically avoiding large meals before bedtime. And the proposed mechanism behind this is that there might be an increased gastric acid production, increased gastric distension, and increase in transient lower esophageal sphincter relaxation. So here is a summary of the evidence listing all the lifestyle modifications. And if you look at the strength of the scientific evidence, it ranges from weak to moderate to equivocal. So even though there's no good evidence or not great evidence, I think we should still recommend all these lifestyle modifications to our patient. Important at the bottom, sleeping on a left side position, and this has unequivocal scientific evidence. In a patient with acid reflux, you would encourage them to sleep left side down. This actually puts the stomach in a dependent position relative to the esophagogastric junction. So if a patient with acid reflux sleeps right side down, you could expect the stomach to be higher than the lower esophageal sphincter, and this could potentially increase nocturnal acid reflux symptoms. Are these lifestyle modifications pathophysiologically conclusive? Yes and no, but once again, I'd still recommend these to all my patients. There's really no harm. Whether they'll be compliant with any or all of these, but I still think it's worthwhile recommending. So something that patients seem to be very compliant with is taking complementary, or the so-called complementary alternative medicines. And Drs. Ahuja and Ahuja in 2019 actually looked at some of these popular remedies that patients might be taking for the treatment of esophageal symptoms. And on the left, you can see a list of some of these preparations that they might be taking, things like apple cider vinegar, melatonin, STW5, slippery elm, licorice derivatives, and they try these for various forms of heartburn, acid reflux. It's listed the hypothetical mechanisms as to why we think that these alternative medicines might work. And you can see on the right that the dose range is really all over the place, a few drops here or there, a small amount here or there. So we're really not sure exactly, how these should be taken. Looking at the bottom, peppermint oil might be better for patients with non-cardiac chest pain. I wouldn't recommend it to a patient who has acid reflux because peppermint actually relaxes the lower esophageal sphincter and might actually make acid reflux worse. So here is one preparation of apple cider vinegar, and you can see this preparation has listed 19 health benefits. Really unclear to me how ingesting an acidic liquid might actually help with acid reflux. We know that apple cider vinegar actually slows gastric emptying, which would probably make acid reflux worse. What is the proposed mechanism? It is thought rightly or wrongly, that ingesting acid might actually downregulate endogenous acid secretion by some sort of negative feedback. Unclear. Patients and providers who recommend these might presume that reflux symptoms arise from a relative state of hypochlorhydria. And I think there's a large placebo response, and often you'll get anecdotal evidence from patients that, taking apple cider vinegar might help with the acid reflux. However, it's important to bear in mind that there's no high-quality data supporting apple cider vinegar for acid reflux. So bring you back to the parietal cell, and I want you to focus your attention at the top, which is the lumen. So we spoke about the proton pump, which is the hydrogen-potassium ATPase. In addition to the hydrogen-potassium ATPase, you have a chloride channel, which pumps out chloride into the lumen. So the combination of hydrogen and chloride is what makes hydrochloric acid. So here we have a potentially novel, and I'm only saying novel because it's relatively new in the United States, but it has been well studied and used for a long time in countries, especially in Southeast Asia like Japan and South Korea. So these are the potassium competitive acid blockers, the so-called PCABs. And this cartoon kind of shows you the mechanism of action contrasting PPI therapy from PCAB therapy. At the bottom left, you can see the proton pump initially in an inactive phase. And when it's inactive, PPIs don't actually do anything. You have to actually allow the proton pump to reach the surface of the parietal cell. And once it reaches the surface, it's then exposed to an acidic medium, and the prodrug PPI is then converted to an active phase, and the PPI inhibits the hydrogen potassium ATPase pump. If you look at the PCAB, which specifically binds to the potassium receptor, the PCAB actually has the benefit that it works in the proton pump that's both inactive and active. So it really works independent of acidity in the stomach. So we've gotten pretty used to all the medications ending in the prazols. These are all the PPIs listed on the left-hand side, and I think we're going to become more and more familiar with the medications ending in the prazans, of which vonoprazan is the most common and most studied, and this is the PCAB that I'll be referring to for the rest of this talk. So PCAB indications here in the US and the rest of the world. The first indication in the US was PCAB-based therapy for H. pylori eradication. This is a slightly older study slightly older slide in that in November of 2023, vonoprazan was actually FDA approved for the treatment of erosive esophagitis. So I just need to add that to the left column there. Approval of PCABs outside of the United States, obviously H. pylori, erosive esophagitis, non-erosive reflux disease, peptic ulcer gastritis, and then there are ongoing studies for the use of PCABs for every other indication that we might use a PPI, Barrett's esophagus, EOE, non-variceal GI bleeding, patients who are pregnant and lactating. So this was the study that got PCAB-based H. pylori eradication therapy approved in the United States. They looked at vonoprazan triple as well as dual therapy for H. pylori eradication, both in the US and in Europe. So if you look on, it's my right, yeah, on the right, looking at all patients with H. pylori infection, you can see the green bar and the orange bar indicate PCAB-based H. pylori eradication therapy, and it was non-inferior to PPI eradication, and this was all patients. When specifically looking at patients with clarithromycin-resistant strains of H. pylori, you can see that both the triple and the dual PCAB-based therapy was far superior, in the high 60% in terms of eradicating H. pylori, whereas lansoprazole-based PPI therapy was only about 30%. So I think maybe to begin with, this is a good way to position PCAB-based therapy for a patient who you can identify as having clarithromycin-resistant H. pylori, although it is indicated for all patients with H. pylori. So this is the formulation branded in the United States. It's a 20 milligram vonoprazan, 500 milligram amoxicillin, and 500 milligrams clarithromycin. So this chart summarizes the difference between the two classes of drugs, the PCABs on the left and the PPIs on the right. I mentioned that PPI is a prodrug, whereas PCAB does not. PPIs are not stable in an acidic environment, whereas the PCABs are acid stable. In terms of inhibition and binding, as a class, PCABs bind ionic bonds reversibly, whereas the PPIs irreversibly bind covalent bonds. In terms of maximal acid suppression after dosing, you can see that vonoprazan reaches maximal acid suppression after 1 day, 1 dose, whereas the PPI as a class reaches maximal suppression after about 3 to 5 days. And this is why PPIs are not good for on-demand therapy. In terms of the half-life, PCABs as a class, 69 hours, much longer than the shorter 1 to 2 hours of PPIs. The difference in half-life is that, H. pylori, acid reflux, nocturnal acid reflux might be a problem in patients on PPI, so that's why you often have to find some sort of alternative treatment for nocturnal symptoms, whereby you'd be hopeful that the PCAB as a class would be effective and durable for 24 hours. In terms of being affected by cytochrome polymorphisms, PCAB as a class, no. PPI as a class, yes. And then, most importantly, PCABs can be given independent of meal times. They can be given before, during, and after meals. And I think this will ultimately be important for patient compliance versus a PPI we know should be given 30 to 60 minutes before meal times. Most PPIs should be given 30 to 60 minutes before meal times. So we obviously needed some studies here in the United States, and this was a pharmacodynamic, pharmacokinetic study looking at the use of vonoprazan in patients here in the United States, comparing them to patients on lansoprazole. They looked at, over a 7-day period, patients taking vonoprazan 20 milligrams, followed by lansoprazole, and then vice versa, patients taking lansoprazole and then vonoprazan. Basically what they found was that those patients taking vonoprazan had higher 24-hour gastric pH than those patients taking lansoprazole. And if you look on the left, you can see that those patients on PPIs versus those patients on PCABs, the PCAB group had a 3 times longer duration of gastric pH greater than 4. And there was a durable response extending up to 7 days, where even after 7 days, patients taking PCABs had a twice as long gastric pH greater than 4 as patients who were taking PPI therapy. It's easier to see on the graph, but you can see that the PCABs reach a much higher and much longer, more durable gastric pH greater than 4 than those patients taking PPI therapy. On the bottom left, you can see at 2.5 hours is when you notice the real difference, because up until 2.5 hours, the acid suppression is similar, but after 2.5 hours, you get that prolonged and durable benefit of PCAB therapy. So this study was done here in the United States, looking at vonoprazan versus lansoprazole, both for the healing and maintenance of healing of erosive esophagitis. It was a randomized trial. It was a non-superiority trial, so they just wanted to prove that vonoprazan was non-inferior to lansoprazole in healing of erosive esophagitis. So in the initial healing phase, after 8 weeks, they looked at 1,000 patients randomized to vonoprazan 20 milligrams or lansoprazole 30 milligrams. On the right at the top, you can see that in terms of healing after 8 weeks, pretty similar. There was non-inferiority between the PCAB and the PPI. But most striking, looking at those more severe patients with LAC and LAD esophagitis, there was by far superior healing of erosive esophagitis in this group, 91% versus 72%. Pushing it forward to the maintenance phase up to 24 weeks, patients were then randomized to vonoprazan 20 or lansoprazole 15 or vonoprazan 10. Once again, looking at all patients in terms of maintenance of healing up to 24 weeks, the PCAB group versus the PPI group non-inferior, but where we saw greater superiority was once again in those patients with more severe LAC, LAD esophagitis, where the healing and maintenance of healing was far superior amongst the PCAB group than the PPI group. So this might be a place to position PCAB therapy in a patient with more severe erosive esophagitis. Looking at the current PCAB trials in the United States, the various phase 2 and phase 3 studies, I mentioned it has been approved for erosive esophagitis, but there are ongoing studies for the use of vonoprazan for the treatment of non-erosive esophagitis, both as a daily dose and as a PRN or on-demand use of PCAB. And then lastly, also being studied for the treatment of eosinophilic esophagitis, which might just give us another medication, to treat EOE. So just in conclusion of my final take-home points, really in 2024, PPIs have unproven safety concerns, but for some reason, patients are concerned to take them, and, primary providers are concerned with prescribing them long-term. We explained the importance of anti-reflux lifestyle modification, however, difficult to ensure compliance. We spoke about patients' preference for complementary and alternative medications. Newly PCAB-based H. pylori eradication therapy. We spoke about PCAB therapy for erosive esophagitis, and look out for new research, new data coming out for PCAB use in the United States for various other indications, just like you would use it as a PPI for any treatment of reflux disease. I thank you for your time. Thank you.